We should move to the next speaker. We have apologized for Dr. Hussam Noor, so I think Dr. Ahmed ElGuindy, he will cover the both topic, antegrade, retrograde, CTO. Dr. Ahmed is the director of Cardiac Center in Sir Magdi Yaoub Foundation in Egypt, and he's a well-known operator in Egypt. Ahmed, we have behind me a very good CTO operators, so I think they will have a very interesting in your talk.
Thank you, Mr. Chairman. Thank you to the organizing committee for the invitation. So it's the end of a long day, I hope, and you're stuck with me with 2 talks back to back, so I hope I won't put everyone to sleep. So we'll move quickly here, and that's the first thing against moving quickly, forget it. So we know that there are some guiding principles how we do CTOs nowadays. But to get to the topic, the antegrade approach remains the most commonly utilized, successful CTO approach. And it's really the bread and butter of what we do. It's, if you can't master your antegrade skills, it's going to be very difficult to become a good CTO operator. And if you break the antegrade approach to different components, they will essentially look like this. We start by delivering a microcatheter to just before the proximal cap, and this is where we establish a base of operations. And then we utilize a number of different crossing strategies, which obviously includes a thought process on the choice of wire, how do we shape that wire, and how do we handle it. And if you manage to cross true to true the AWE, or antegrade wire escalation, you want to ensure that this wire is in the true lumen distally. And if you fail to enter into the true lumen, you want to have a plan B and C for how can you re-enter into the true lumen. Then we exchange for a workhorse wire, remove the microcatheter, and do our stenting. So this is an example of how you would walk into a non-CTO PCI program, an LED, a short segment, an operator trying with a fielder XT without the support of a microcatheter, and you can clearly see that this is stuck in the extra plug space. So just by following the simple rules of CTO PCI, so we have a dual injection now. We're doing 2 injections with the donor vessel first. We see the distal cap, then we do an antegrade injection, and then we have a full understanding of what's happening on the proximal cap, on the distal cap, what exactly is the lesion length, and whether the course is ambiguous or not, and we can also appreciate the presence or absence of collaterals. So then it becomes a very easy procedure, same guide wire that was used initially, but bent and shaped as a CTO wire. And then you can appreciate that this is crossing smoothly into the distal true lumen. So with antegrade CTO PCI, I think this is landmark work by Satoru years ago, and it just shows that even in very long CTOs, those have been there for more than 10 years, you would see in 70% those microchannels. And those microchannels, as a matter of fact, traverse the entire length of the CTO segment. And surprisingly, to some extent, they are present in more than 70% of cases, regardless of the age of the CTO. And this is exactly why the polymer jacketed, the low tip load, polymer jacket tapered guide wires were developed because they are able, because of the tapered and polymer jacket, to engage those microchannels and to slip easily through them. And when we look at the different morphologies of the proximal cap and the CTO segment, you really want to understand whether this is a tapered proximal cap, and that usually entails that it is clearly defined or non-ambiguous, or is it a blunt proximal cap, be it ambiguous or not. And you also want to understand whether there's a lot of calcification within the CTO body or not. So how do we think about wires? Well, you wouldn't go wrong if your first choice in the vast majority was tapered polymer jacketed wire, the Fielder XT family, be it XTA or XTR, because again, you're capitalizing on the fact that 70% of those lesions will have microchannels that traverse the entire length. Now, if that doesn't work, especially if the course of the vessel is ambiguous or unclear, it becomes a bit counterintuitive and unsafe if you take a stiff wire, a Gaia 3rd, for instance, a CP12, and try to navigate through a vessel that you don't fully understand its course. So this is why a polymer jacketed wire, although they can exit into the extra plug space, they will tend to remain within the vessel architecture. That means that you can end up in the subintimal space distal to the lesion, but the likelihood of puncturing or perforating the vessel and ending into with a perforation is minimized. So these are particularly useful, be it the Gladius, Pilot 200, Braider, and those all are polymer jacketed wires, non-tapered, and they have a tip load of between 3 and 4 grams. So what happens when you have a lot of calcification, either at the proximal cap or inside the CTO body, then this is where the tapered, high tip load penetrative wires come into play, and this is the CP12, Hornet 14, Astato, Warrior. So these are all good choices. Now, if you're within the CTO body and you really want, and you understand the course, and you really want to have good one-to-one torque control and to control the course of the vessel and navigate around those calcified spots, this is where the Gaia and Gaia Next family comes into play. So this is from Manos Brilakis' textbook, and you can appreciate that although we do deviate, but that's a general map for how we think about antegrade wire escalation. Now, we've all seen this before. This is how we shape the tip of CTO wires, a 1 millimeter, 45 degrees bend. And the reason is you want to navigate within submillimetric temporal patterns. So you don't really want to go very distally or very eccentrically close to the adventitia. And also, whenever you're rotating a large tip, you end up with creating a large hematoma within the plaque or extra plaque space. And the only way you can do that if you actually exit the wires through the distal tip of the introducer and do your shaping rather than do it on the side of the introducer. So again, so how do we think about our guide wires? I want a regular floppy wire as a workhorse wire. I need to have a tapered polymer jacketed wire, and a polymer jacketed wire, the non-tapered polymer jacketed wire with an intermediate stiffness by the 200 Gladius or Raider, a tapered high tip load penetrative wire, a deflection rotation type of wire, which is the Gaia family, and to a lesser extent the Judo family, and those are for the retrograde approach, so you forget about that. With wire handling, in all honesty, we have only 2 ways we move wires. There's no science behind that. We either rotate them or we push them and pull them. So you can create a number of different combinations of those, be it a combination of pushing and pulling, or the sequence, or the speed or force that you do that with, but this remains the only 2 ways that we can control wires. So in the vast majority of instances, we will use a sliding rotation, especially for the polymer jacketed wires. And when I see people doing sliding, they just go very slow. This is a quick, rapid rotation of the wire, and you're sort of probing the proximal cap, aiming for the tip of the wire to fall into one of those microchannels. So we do it briskly. We hardly do any pushing motion. This is mostly a probing, and your left hand is doing all the forward work, which is kept to a minimum. Then, when you're faced with a lot of resistance and a lot of calcium, you want to do some deliberate drilling. And with drilling, you are applying some forward force. These are penetrative wires. And drilling is usually a combination of penetration and intentional pushing forwards. And then the rotation deflection, when the Gaia family was introduced, you would not see a Japanese operator really drilling a Gaia wire. Having said that, the vast majority of us would still do it, but the wires were built on a single principle that they will not penetrate right through calcium. So whenever they're faced with calcium, they will start to buckle. And the proper way of handling a Gaia wire is a gentle rotation. When they start to buckle, you would pull back slightly, redirect, and because the torque control is excellent, literally 1-to-1, this would navigate around the speck of calcium without introducing a lot of whipping artifact. So this is how we would do sliding in real life, and I'm conscious of the time restraints. You can see that we're gently probing the proximal cap and seeing where that polymer jacketed wire. Now, if you push with your left hand at this stage, it's just going to buckle. They don't have a lot of stiffness in them. So again, this is how the Act 1 technology within the Gaia family allow for perfect one-to-one control. This is what you see on the top panel. So once we've crossed the CTO segment, you really want to make sure that, number one, you are in the vessel architecture, because a wire-based perforation is safe in the vast majority of instances, but if you advance your microcatheter or a balloon outside the vessel architecture, this is where trouble starts to happen. So the first thing is to make sure you're in the vessel architecture. Doesn't really matter at this stage if it's true lumen versus subintimal, but if you're in the vessel architecture, we can move to the second stage. The best thing is to do an orthogonal views, contralateral injection into orthogonal views, but sometimes that's also difficult to determine, especially if the visualization is poor or the vessel is very small. So the best thing, next alternative, would be to test a workhorse, non-polymer jacketed, non-hydrophilic wire. And if that flies smoothly into the distal part of the vessel, it usually signifies you're in the true space. Now, if you're still in doubt, IVUS can be extremely useful. Aspirating blood from the microcatheter is not really reliable, because if you have a large subintimal hematoma, you can still aspirate blood, and you're still in the subintimal space. And the last thing you want to do, which we strongly discourage, is injecting from a microcatheter, because if it happens to be in the subintimal space, your case is ruined. You'll introduce a huge subintimal hematoma, you collapse the distal true lumen, and then you really run out of options. So that's an example of contralateral injections, and it's not working. And this is an example of a distal injection to ensure we're in the true lumen. You can see that we destroyed the vessel with a huge hematoma. And then, because of that, we just had to end this case with a knuckle all the way starting down the vessel, and we ended up as an investment procedure. So, method here is please avoid checking by a tip injection. I'll ask for 1 more minute, please.
Because you have to move to the
yes,
next
exactly.
one.
So we'll keep the flow.
Okay. Yeah. So you can mix both together.
So this is how the IVUS would look on the left-hand side. This is a volcano system. So you can see that the catheter is in the false lumen at 1 o'clock, and the entire vessel is shifted to one side. This is how an subintimal position or an extra plug position of the IVUS catheter would look like, as opposed to true lumen on the right-hand side. So if you're stuck in the subintimal space, I think this is an entirely different talk with how to do ADR, but these are the different options we have. Some of them work very well, some of them we still don't know, and some of them, as a matter of fact, they don't work, but that's a different talk altogether. So with that, I think we've done with the Antegrade talk. Can we put the other talk, please? Yes, the retrograde presentation. And I think we can leave the discussion till the end.
No, yes, we put the discussion there.